go for exam scenario, there are either two things. One thing is the traditional way. Traditional way means the initial 3 to 4 candidates have to give their exam in the following way. You have to present your entire history, entire examination, and entire viva. So for this thing, what I'll suggest to you is, one is your whatever notes you have read till now of your entire COM squamous. COM squamous is not a single chapter. I'll say it's an ocean in itself, which comprises n number of topics, n number of discussions can take place. So mind one thing, your questions will generally initially will be the standard questions that will be asked, and after that, whatever you will utter, from that only the question will be made, and it will be asked to you. Okay. So, and second thing is, notes ke alawa, second thing you have to go is Scott Brown. Third will be your Shambog mein, there is only one chapter which is important for your practical session, that is your complications of COM. And after that, excuse me, just a minute. Sorry. Take. And after this complications of this thing, third thing which you have to go about is the 20 pages which I have shared to you. I'm sorry, the 12th page is missing in that. I'll see if I can get that. If it's not there, you don't have to worry. The questions have already been covered. The important thing is, in these 20 pages, almost all of your viva questions that are routinely asked are summarized, and all your answers are there at one place. Please go through them, and whatever the recent advances over here. Now, this thing will be there for the initial few candidates, and the examiner will get bored. Okay, so he'll not listen to you for every details which you are answering. So you have to prepare yourself that, okay, summarize your case. What are your positive findings? And most important is this: how will you manage the case? How will you manage the case? So you have to think it on these grounds, that if you are sitting on the other end of the table and you have been asked these cases, that how will you manage the case? So in the entire session, we'll be dealing with the whole thing. How we'll go with the history, traditional history taking examination, that will be seeing in the second half, and how will we answer this thing, that how will you manage the case? Okay. So first you summarize the case, whatever the positive findings you will be having, and after that, when he asks you how will you manage the case, so my take will be that you should say, sir, I would like to evaluate the patient further. Okay. So my take will be, sir, I would like to evaluate the patient further. Okay, doctor, so then what would you like to do? Sir, I would like to do a PTA for this patient. Okay, why PTA? What inference do you get from PTA? Sir, for PTA, we'll do because we will get the degree and the type of hearing loss. One. Second is the documentation. We all know that it's a world of medico-legal scenario these days, so it's always a medico-legal document. Okay. After PTA, what would you like to do? Sir, I would like to do automicroscopy. So why is automicroscopy important? Because you have to confirm the diagnosis, suction clearance. You can see the site of granulation tissue. What is the status of ossicles? To confirm the sites and the margins of perforation, exact site of origin, and posterior limit of cholesteatoma can be seen. Okay, see, these are entire during the times when I made notes and all. So entire things are given over here. I've taken a snippet from that itself. Whatever you can learn, 3-4 points you should be able to utter without fumbling. Okay. After this, the third thing I would like to do is the X-ray mastoid. See, over here, as I've told you multiple number of times, these answers depend upon scenario to scenario, upon examiner to examiner. The same examiner might screw you if you say that, sir, I would like to do X-ray mastoid. So he might shout at you that in today's world, of HRCT, you would like to do X-ray. Okay, so he might have you on this side also that when you have X-ray available, why do you want to do CT scan? And on the other side, if you say CT scan from your side, if I will go for HRCT temporal bone, then also you might get a thrashing from the examiner that you have just passed and you are going for HRCT. Why will you not do X-ray mastoid? Okay, so one take will be that you can go as per your institutional protocol. What you are following is that you can go. Otherwise, start with the basics. Yes, sir, I would like to do X-ray mastoid to see the pneumatization, to see the sigmoid sinus, to see the dural plate. And after that, sir, I would like to do HRCT because of my, as per my experience. Now, coming to HRCT temporal bone per se, there are some people who are experienced, those who are old timers. They generally don't do HRCT temporal bone. They are full on boss of themselves, boss of wizard of pathology. बोलते हैं कि they will do everything. I'll see on table, I'll manage it, not an issue. But as the recent advances take place, the availability of CT scan is there. So it's like some people do HRCT TB beforehand only. So it's up to you what you would like to answer. So you have to defend it basically. The thing is that you have to defend yourself, whatever you say. Okay? दोनों ही सही है. No, nothing is wrong. But whatever you are saying, you should be able to defend it. Okay. What you can see in HRCT temporal bone is level of dura you can see. The sigmoid sinus का level आप देख सकते हैं. ठीक है. What's the level of jugular bulb? That you can see. What is the root of facial nerve? That you can see. What is the status of ossicles, any fistula? All these things can be seen. Okay. So as you can answer as per your institutional protocol, that will be my take. The only thing is, whatever your answer, you should be able to defend it up. Okay. Now, okay, doctor. So the surgery you are performing for the patient, for squamous squamous, what will be your surgery? Sir, I would like to go for tympanomastoid exploration for this patient. And as per my experience, as we were taught that as per your experience, you should answer canal wall down. Okay, so that's why that is my take. That's how we used to answer in our institution. That sir, based on our experience, I would like to go for canal wall down. And just this thing I uttered in my main viva, I got a checkpoint from the examiner. Why will you do canal wall down for the patient if you are not able to do, if you're not competent enough, why don't you refer the patient? See, that's the thing that this will come back to you again and again. As far as today's scenario is concerned, people do intact canal wall, or people might do canal wall kiya and limited canal wall down kiya, and reconstruction procedures all are there, so that they'll reconstruct everything as it was beforehand. So this you should be able to defend back. Okay, what will be the aim of your surgery? What are you doing for the surgery for? So, sir, my first aim will be that total eradication of disease should be there. Second, sir, it should be that I will be able to restore the hearing and the normal anatomical appearance I would like to perceive at the end of surgery. That should be my third priority. Okay. Over here only, a tough thing is there. Answer we have shared multiple number of times. Canal wall down, canal wall up. Okay, what are the advantages? Disadvantages. One, same one. Okay, this should be your module. Okay, go through those 20 pages again and find it over there. If you are not learning it now, please learn it. Over here only, please see. Okay, what to learn it. Types and boundary. Second is your facial basis. And third is your prosaic space. See, whatever questions I'll be writing on this corner, in case you are not able to find the answer, do drop me a message. Okay, this answer is not available or any doubt is there, so that we can share it on the group and it should be a smooth sail out. Okay, so then the very famous question of most of the examiner is, why do you say it's squamous disease? As soon as you'll say कि sir, in the diagnosis you'll say कि sir it's a chronic otitis. हाँ, ये नहीं बोलना है, सीओम स्क्वामस मत बोलना, ठीक है? It should be full chronic otitis media squamous. Okay, short forms are to be avoided in your practicals. Please remember it. Okay, so he'll ask you, doctor, why do you say it's squamous? So this you have to defend whatever you have said. So in your history, what you would have said is, what will be the history? The classic history is, sir, the discharge is foul smelling, blood stain, scanty, and continuous. Okay, so doctor, can somebody unmute and tell me why the discharge is foul smelling in serum squamous?
Proteus infection and bone erosion.
Okay, great. Okay, so your answer is absolutely correct. One word that you have to use over here is osteitis. Okay, so this is the keyword that you should include in your answer. The answer is absolutely correct. Okay, so there is a continuous osteitis going on. So because of which there is necrosis of bones, a lot of granulation tissue is being formed, and leading to this, the discharge is blood stain and foul smelling. There's a lot of granulation over there, because of which the blood stain is there. And why is it scanty? It's scanty because you see what happens in mucosal. In mucosal, what happens is there is basically the middle ear mucosa which is involved. And which cells are found in your middle ear mucosa? These are goblet cells. So these cells keep on vomiting out the mucosa. Okay, so that's why there is profuse discharge in your mucosal, whether is compared to the scanty discharge of your squamous, which is because of the osteitis and this erosion of the bones per se. Okay, and why do you say it's continuous? So because the process is a relentless, continuous process of erosion of the bones, and that's why the discharge is continuous as compared to the mucosal. Like, because in mucosal, what history will he give? That sir, in certain times there is profuse discharge. That even my pillow is stained and discharge is coming out. I put the cotton and it gets all stained. But that's generally not the case in the scanty type of discharge of squamous. In squamous, what he will say is कि sir मैं उंगली डालता हूँ तो मेरे को अंदर लगता है कुछ गीला है, but generally it's not coming out. Okay, so these are the 4 points that you should say in your history. That so because of these, I'll think my answer goes with the squamous thing. Okay. After this, what thing will be there? Okay. Second question is this. So can somebody unmute and just tell me the name of retraction of past tensor retraction? What classification do we use?
The classification.
Past tensor is?
States classification.
ठीक है. And Placida we use. There's no one in telling past classification. ठीक है. So please remember it. ठीक है. This is your very important question. पूरा category wise याद रखना. In this, I would just like to make a point. Many people, old examiners pronounce it as Sade classification. ठीक है. This can be a ambiguity also, but this is what I heard from my seniors, that there is one symbol like this made over the side A in the states classification. So they call it as Sardis classification. Okay? Then I leave it to your wisdom what to call it. Okay? You can use Google and all and check. Okay? And iterate accordingly. Not important. That's not important. Important thing है कि इसके अंदर तुमको पता होना चाहिए 1 2 3 4 1 2 3 4. ठीक है? You shouldn't forget this. ठीक है? Again, this is a tough question. ठीक. इसी के साथ over here again few questions. What questions? One is tympanoplasty classification. Wolstein, nobody asked. Okay, but you have to remember it's like the grand anatomy days. Nobody asked the femoral triangle, but याद सबको करना पड़ता था. Supposedly in our university it used to be a start question, but never came in the entire year. So same goes with Wolstein. Everybody says, but now nobody asks it. ठीक है. Second, the TOS classification is important. ठीक है. Please remember it. ठीक. इसके अलावा मेरी इंडेक्स. ठीक है. मेरी इंडेक्स के अलावा two things are again connected in the same thing, that are oops and spite. Okay. Again, a small request to all of you. If any of the terminology is not clear to you, please stop me again. Okay. For the June guys, it's a revision. Second time they are going with this thing. If you are seeing it for the first time, and if you feel that something is like going out of the head, please don't make it. These classes are not like वो जो college या वो वाला नहीं है कि PPT change कर दिया. No, not the scene. ठीक है. Anywhere you get stuck, please stop me. Nobody knows you, nobody knows me. Okay, so ऐसा कुछ नहीं होगा कि मेरे को इतना ऐसा doubt है. Whatever, yeah. We have to answer this and pass the exam. Get out of this shit. That's most important. Okay, Mary is important. Why is it important? That I think that this can be used for a viva question. Whenever you are answering your in the viva, in the examination finding, after you exam, like in the middle year, after you say the findings of tympanic membrane, just mention, sir, Mary's score is this. And as soon as you say Mary's score is this, be ready that he will ask you, Acha, what is Mary's? So you can start with your middle year risk index. So these are the factors which you look at the Mary's. This is the score, and this is what it denotes. Okay, and this is the second question which comes. This is more of an OSCE type. Any other thing which you know apart from Mary, that is OOPS, ossicular outcome processes, and spite thing. So these two only name if you will remember, that too is also okay. And after this, यहाँ पे ही दो चीजें और है. Well, first rule of thumb. So this you should be ready to answer. Okay. So we come to one more topic of I'll say not viva. Like any questions can be asked from this thing. In case of congenital and pediatric cholesteatoma, one thing is definition, and one thing is the types. Okay. So we'll just see the definition what's over there in the next slide. In the types, please remember the name. Drelaki and Clemens criteria. Let's go to the next page straight away. Okay, so any definition you can remember. This definition is from the Scott Brown itself. Okay. You can remember in your own languages also. Like generally it said that definition should be learned by the book as it is, but practically it's not possible. Okay, so whatever way you want to learn, please learn any one definition of squamous. And coming to this thing is the Dolakian-Clemens criteria, which was modified by Levinson later on. Please remember these four things. That is, one is your pearly white mass, which will be medial to intact TM. Okay. एक दूसरा is normal pars flaccida, normal pars tensa. There is no prior history of otorrhea, and there is no prior otological procedure as well. So these are the Drelaki and Clemens criteria. This can be a part of your squamous OSCE. I'll tell you the OSCE which was asked last to last session. There was a image of tympanic membrane, autoendoscopy image was given, in which there was a lot of cholesteatoma which was seen in the attic region and all. And the first thing was asked that what finding do you see? So you have to tell that there is cholesteatoma present over here. Usme they can ask these type of questions, that what if the Lacan Clemens criteria, and one or two other things they can add. Similar one question was asked giving the clinical history, that there was a patient of cholesteatoma who underwent this mastoid surgery, and after mastoid surgery, while cycling, he had an episode of giddiness and he fell down. अब उसमें पहला क्वेश्चन था what could be the reason of this giddiness. Okay, so because they are giving this history of mastoid surgery, so we should remember that there is a air caloric phenomena, because of which as soon as the mastoid cavity which has been widened, उसमें जैसे ही this air and all touches, so it initiates that air caloric phenomena, and the person might experience giddiness. Okay, so coming back to this yeah. So there are certain theories which you should remember. This why I have included. Personally speaking, I am not very big fan of these ratification things, but that's the unfortunate situation. After 4 months of examination, we are expected to answer everything in theory, learn and answer. Practically, there is nothing practical in this. Okay, and I've seen the same question being asked when, as a first year, we were seeing the exams being conducted in our institute. And the viva, the people who came for taking viva, they were stuck on this question. Please tell me what are the theories of cholesteatoma. Okay, and if you get stuck at one point, so they'll be like tell, and ultimately after 1 or 2 minutes you lose it. You say, I don't know. And so these are the things which you should remember, because people like person who are old timers now, they are very fond of asking these things: definition, classification, what are the theories. So that's why I just included this thing. Small mnemonic for this thing is time farts. T for Teach theory, M for Michael theory, F is for Friedberg's theory, A is for Amy theory, R is for Rudy theory, T and S for Toss and Sardis theory. Okay, so you should remember the name, and after the name you can remember any one or two. Okay, I'll not say that sab kuch yaad karo. Ultimately everything remains the same. The fun fact about ENT is almost most of the things are same, only as the time changes, scientists will do some modification, name will change, and he will publish something, and the poor resident has to remember everything. I don't know why, but pass होने के लिए याद करना पड़ेगा. Okay, so my take will be, as soon as you are asked what are the theories for your pediatric cholesteatoma, so you should like तुरंत तो flow में जाना चाहिए. Sir, Teach theory, Michael theory, Friedberg theory, Amy theory, Rudy theory, Toss and Sade theory. ठीक है, and after that if you letter like this, he'll not even ask also. He'll not even bother to ask you कि अच्छा अंदर बताओ क्या होता है. Otherwise, you should be ready for one or two. Teach epithelial theory states this, and this imagination theory or implantation theory of Friedberg states this. Or one or two you should remember in detail. Okay. Okay. Coming ahead. For staging of this pediatric cholesteatoma, again 3 stagings are used. Please remember the name. One is the Lacan-Clemens staging. Second is your Osicki staging, and third is your Nelson staging. 1, 2, and 3. Please remember the name as well as the classification in between. Okay. So then comes a very favorite question that, so what's the difference between adult and pediatric cholesteatoma? I'll answer one point as of now and will leave rest to your imagination. One will be that pediatric cholesteatoma is more aggressive as compared to the adult cholesteatoma. Okay. So please go through more details of this. Over here only 3 things. 1. Difference between adult versus pediatric temporal bone, adult versus pediatric mandible, and adult versus pediatric larynx. Okay, now coming to the next part of the discussion. Now, there are 3 classifications which will be used over here. These classifications are basically done to standardize the process or standardize the surgeries which are being taking place. So, we'll be discussing about them in a nutshell. Okay, the first thing is Stamko classification. So, this is the diagram of Stamko. This is a very potential OSCE based question. This kind of image can be given to you. And you might be able to, you might be asked as what is A, B, C, D, X, Y, Z, इस तरीके से करके जो आपका S1, S2, A, T और M लिखा हुआ है, that can be identified from you. Okay, 1. Second thing is this is like involvement of cholesteatoma. S1 states the difficult anterior area, S2 is the difficult posterior area per se, that is the sinus tympani and all. And A, T is for tympanic cavity, A is for attic, M is for mastoid. Okay, similarly goes for C and O classification. In C, we will be having extracranial as well as intracranial complications. And ossicles are basically depending upon the status of ossicles and whatever ossicles are destroyed by the cholesteatoma. So this is the first classification that you should remember. Then comes its 2 distant cousin brother. One will be by the name of Poli classification and second will be by the name of Iono-Jaws classification. Okay, full form is important. You should remember the full form per se and the image associated with these classification. Okay, then there is one classification called as Samio-Atto over here. Samio-Atto is a operative classification. Means I hope I don't know whether you people like it's being used in your institution or not. Like in Samio-Atto, it's basically depending upon what all procedures, what all steps have you followed for your surgery. And depending upon that, it has various subcategories into its each section. Like what is the approach? So it will have 1, 2, 3. Like its post-auricular approach, end-oral approach. Uske hisab se you have to answer it. So there is a even a separate app for this. And apart from that, there is a link basically for Samio-Atto. So as soon as you click over it, so it will ask for the details, and you will keep on filling. At the end of as you fill off this. Around 8 things are there. So it will give you what is the Samio-Atto grading for your surgery. Okay. So please remember Samio-Atto. I'll share the link with you guys of Samio-Atto. So if you are not following this thing, kindly abhi agar if you are attending OTs, try fulfilling 2-3 things over there. Okay, so after these 3 things, let's come to the big daddy of everything, that is cholesteatoma. Cholesteatoma mein 2-3 things you have to remember. One thing will be definition. Any definition you can remember. One is the first one, the traditional one given by Abramson. Second will be by this, which is given in Scott Brown, and third will be which is given in Shambog. Whatever you want, you can remember any one, but jo bhi yaad rakhna, if it's better that you remember the source which you are answering. Okay, so over here it's given in point-wise method. So you can go according to that. That it's a 3D epidermal and connective tissue structure forming a sac, which is important, composed of stratified squamous epithelium and conforming to the middle ear cleft. Okay, and basically it has capacity to progress. It can go anywhere, and it can cause the involvement, like it can erode the bone which is underlying it, and it has the tendency to recur. Okay, so anything you can remember, but please remember it fully. Okay, coming ahead, what are the theories which are associated with this cholesteatoma? Again, you have to remember them. Rectification question hai. Please, you cannot afford to forget it. Okay, so this is how I remember it. TB में CI, मतलब cochlear implant कर दिया आपने TB में. So T for tumarkin, B for basal cell hyperplasia, M में only for metaplasia theory, and CI is for Cawthorne as well as invagination theory. Okay, so ratification, and then comes these are the details of these theories. Anybody interested, please go through it. Okay, nothing new in that. Now this is the latest theory of cholesteatoma which I could come across. That was in 2015, given by Jackler. Again, this can be a OSCE question or a one-liner question, that what is the recent mucosal traction theory? What does it state? So it was given by Jackler, and in which year? 2015. Okay, so I've written it in a flowchart point of way. Please go through it. Okay, so let's go ahead. What is this? Okay, this is again a very favorite question. So Doctor, you say that this cholesteatoma is eroding the bones and causing all the destructions and all. Okay, so tell me what is there in this cholesteatoma that will cause this destruction. So these are 3-4 names which are source is Scott Brown. Okay, so this you can answer. One is your metalloproteinases 2 and 9, TNF alpha, interleukins, rank ligand, Ki67, and caspase activation. Okay, so please remember it. It's an important viva question. It can also be attached question, a subset question of your any OSCE based question also. Now coming to again, these questions are given in that booklet, not booklet per se, those questions which were shared. What are the DD of chronic discharging air? What is the DD of cavity in mastoid? Very important question. Okay, what are the features of ideal mastoid cavity? When will you say it's ideal mastoid? How will you make it ideal mastoid cavity? What is meatoplasty? What is mastoid obliteration? What things do you have for obliteration? Okay, so ये सब rectification है, वो 100 questions है, उसको चार्ट जाना, याद कर लेना, छोड़ना नहीं कुछ भी. Okay, so what are the DD of chronic discharging air? One is COM that we are studying. Second will be your tuberculosis. Then third will be your malignant otitis externa. This is an important chapter. Please revise it completely. Squamous cell CA, foreign body retained in your ear. So all these can be a cause of your chronic discharging ear. In squamous cell CA of EAC, another OSCE based question is your name of classification. Okay, I'll by the end of class, if somebody posts it, I'll be grateful. Else I'll send it in the group. Okay. Now coming to DD of cavity in mastoid, again a very favorite question. So the first will be cholesteatoma itself. The second will be again TB. जहाँ पे इंडिया में आंसर नहीं समझ आए, tuberculosis बोल दो. ठीक है. Most of the cases it will be correct because it's such rampant. Okay, then there is granulation tissue, then there is operated cavity,
Multiple myeloma.
multiple myeloma. Great, Doctor. Multiple myeloma, then there can be tumors, there can be secondaries. Okay, I'm looking from the whole list which I have. That's why I answered everything. You can answer 2-3 and you should be sure that you'll cross 60-70% in this squamous. Okay, other questions which can come is again, other questions. Meatoplasty. Second will be your mastoid obliteration. What materials are available to you? What flaps will you use? That is very commonly asked to you. 2 हो गया. इसके बाद तुम्हारा ये हो गया, क्या कहते हैं, अच्छा जस्ट एक बार इसी के थ्रू. 1 is posterior tympanotomy and approaches to, I'm just wavering from this topic, approaches to CI. ठीक है, ये important question है. चलो, now again questions coming from tuning fork. See, question which we are discussing, तो अभी जब case we will discuss, so we'll go it in a flow, will not break it in between, है ना. So we should remember the tuning fork में what all questions can be asked to you. Okay, so first question is that you should be able to answer the body of tuning fork. These are the prongs, this is neck, this is shoulder, this is the base, and there are multiple types of tuning fork. Okay, and in the coming to the tuning fork test, the first one will be Rennie's. Okay, the Rennie's में 256, 512, 1024. So there's no fun in telling. We all remember by now what is positive, what is negative, what is false positive, what is false negative. Okay, where will Rennie's go, where will Weber's go, when will ABC be reduced? ये हमको सबको पता है. Okay, the question which is generally asked in viva is कि 256 Rennie's becomes positive at what decibel of hearing loss? Can somebody take a try?
15 decibels.
15 to only 15. कुछ है range, हमेशा answer in a range.
30.
15 to 30. Okay, and this 512.
30 to 45.
And this will be more than 45
to 60.
45 to 60 हो गया. Now second question will be which tuning fork test is most sensitive? What will be your answer?
512 sir. अच्छा Weber's.
Weber है, ठीक है. So be ready for this question that it lateralizes as less as 5 to 7 decibel hearing loss पे it will lateralize, जबकि tuning fork में Rennie's में 15 decibel का hearing loss is required. See, ultimately on ground it doesn't make any of the difference, ठीक है, but in exam it makes lots and lots of difference, ठीक है. So you should be ready to answer. Okay, over here Weber हो गया. ABC हम लोग करते हैं, ABC you will answer. Then there is one test which you do for malingering. Okay, so what's the name of that test? Very famous, very common OSCE question.
Stenger and Shimani-Moose.
Shimani-Moose test.
Great, Dr. Sab. Stengers and Shimani-Moose. Okay, so name both of them and detail of this Stengers. Okay, what is Stengers phenomena? What is Stengers test? Please go through it. Okay, now moving ahead. Whenever you are doing your examination of ear, we will see it again also. It will not be completed without the otoneurological examination. Okay, it will not be completed without the otoneurological examination. So be ready to examine all the cranial nerves, especially the 7th cranial nerve. You cannot afford to forget. Okay, so that you have to tell. Okay, इसके अलावा जब ये खत्म करोगे, last point will be your fistula test. We all have read what is fistula test. See, one thing is, if the examiner asks you, Doctor Sahab, what is fistula test, and you tell him, sir, if there is any fistula over the semicircular canal, so when we will press it, the patient will experience giddiness. तो ये तरीका हो गया answer करने का. And anything is asked to you, try to break it down in 3 things. So the principle behind the fistula test is so and so. The method of demonstrating is, sir, we can either apply pressure to the tragus by our finger. Second option we have is by Siegel's speculum. And third thing, sir, this is the interpretation. Okay, so if you will divide it into these subsets, so your numbers, your passing probability will increase exponentially. Okay, similarly, like something is asked you, what is the DD of this thing? तो एक आंसर तो ये हो गया कि ठक 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 जो 4-5 आता है बोल दिया, randomly बोल दिया. The second method is divide it into the जो traditional MBBS हम लोग याद करते आ रहे हैं, congenital, inflammatory, infective, okay, traumatic, tumor will be again benign, malignant. So once you divide it, so your that जो आपका एक वो like the effect which you'll have on the examiner is good. Okay, so that is important. And after this, it will not finish before you examine the nose. Why is nose important? He'll ask you, sir, in cases of bilateral diseases, many times there is a central pathology which is sitting in the nasopharynx that might be responsible. One, second times, many a times there is a very high third grade 3 DNS which is there, which can be like leading to eustachian tube dysfunction, and subsequently leads to your like CM squamous में help करेगा. Okay, so this you can answer. Now coming to the diagnosis. Okay, so doctor, what's your diagnosis? Generally, see, this is what we followed in our institution. You can modify it as per your institutional protocol. Okay, yes, sir, itna-year-old male, female, chronic otitis media, left side, squamous with moderate conductive hearing loss, with or without any complications. Generally, you will not get any case which is having complications. नहीं आता है. ठीक है, तो if it is there, complications are there, तो you have to mention कि sir with so and so complication, and if it's not there, so you have to mention without any complication. Okay, so let's go ahead into this long case presentation. Okay, I'll just go ahead with this, and whatever are the questions, I'll try to take them also, which are along with this. This case was presented in the NB forum. Okay, this DNB used to organize this I'll not say monthly, around 3 to 4 months where they had this type of cave discussion in which voluntarily they used to be who will present. So somehow I had this privilege, or not the privilege, whatever you can answer, of presenting this case. So whatever questions were asked, I just jotted it down after this, though I was not able to answer most of them. So we'll try to take it there only. Mr. Gaurav Tripathi, male, age so and so, resident of Delhi, presented with discharge, left ear since 1 year duration, decreased hearing both ears since 1 year duration. Okay, so the question over here should be what are questions? I'll just mention over here only. What are the cardinal features of ear disease? And second, describe the discharge in squamous disease. Okay, after this class, I'll share with you some videos which of this classical CM squamous cave discussions of DNB. Okay, so you can go through this. The questions remain same. Ghuma fira karke, it's almost 100-150 questions are there. Apart from that, nothing will be asked. Okay, so we all know what are the cardinal features of disease, the discharge which can be there, the otorrhea, basically the hearing loss, and the otalgia which can be there. Okay, discharge, will describe the discharge also. Okay, sir, discharge is scanty, it is foul smelling, it is blood stained, it is continuous. And जैसे तुम ये बोलोगे तो he will keep on asking why scanty, why blood stained, why foul smelling, why continuous. So be ready with the answers. ठीक है? Coming to the history of present illness, long case should be completely written. Okay, if the examiner asks you, he might even ask you, give me the case sheet, and then he will ask you to answer. So it shouldn't happen कि तुमने उसमें केवल scribble करके रखा हुआ है. You have just scribbled it out and handing it over to the examiner. You have made certain 2-3 fancy designs and handing it over to the examiner. So this shouldn't happen. Keep it clean and mention the requisite important details. Okay, so coming to history of present illness. So the discharge was insidious in onset, continuous, thick, purulent, greenish in color, whatever you want to answer, scanty, blood stained, foul smelling, and discharge. Over here you have to bring it out. You are telling ki bhaiya, this is squamous, not aggravated by URTI, not relieved on using topical ear drops, no other aggravating or relieving factors. Over here 1, 2, 3 questions are there. One is same, why scanty, why the discharge is foul smelling, why it is profuse, what is the difference between squamous and the mucosal disease based on history? How will you tell? Doctor, stop over here. Based on the history itself, how can you say it's squamous or mucosal? So you shouldn't falter. Okay, moving ahead. The patient also complains of decreased hearing both ears since last 1 year, left more than right. Its onset is insidious, it's progressive, continuous. He cannot hear whisper from the left ear and has difficulty in hearing the conversation which is affecting his routine work. And he uses mobile phones with his right ear. So you are telling the examiner that this patient is having like significant hearing loss on his left side. Okay, over here, one question which was asked: what are the causes of fluctuant hearing? Now, can somebody again unmute and break the monotony?
Meniere's disease.
Okay, ओके, तो पहला एक आपने बोला फिस्टुला, ओके, और कुछ बोला? Meniere's disease.
Sir, the cholesteatoma can act as a bridge for conduction of the sound.
So how will it cause fluctuant hearing? That is called as
So
cholesteatoma
CSIM
hearing.
with discharge, they'll be having decreased hearing, and CSIM
Active
with
discharge.
inactive will improve the hearing.
Okay, that's great. Doctor, just I wanted to clear that point. That is called as cholesteatoma hearer. Okay, if that cholesteatoma has already destroyed, engulfed the ossicle, and it is like acting in the same place, so the patient is like hearing okay, and once you remove the cholesteatoma, the hearing drops. Okay, so that is cholesteatoma hearer. This is fluctuant hearing. Fluctuant hearing का मतलब है कि कभी ऊपर जा रहा है, कभी नीचे हो रहा है. Okay, so this is a very favorite question of the examiner. Okay, coming to the negative history, sir, there is no associated ataxia, no tinnitus, no vertigo, no oral fullness, no history of fever, no swelling behind the ear, no facial asymmetry. Now over here we are ruling out the complication. Okay, so every negative history that you are saying, you are ruling out complications. Okay, so what all complications can be there, we'll just discuss in a nutshell. Please read Shambog का edition पढ़ना है वाला. If you have any difficulty in that, tell me. I'll send that PDF. Around 7-8 pages are there. Please go through it. It's important. Okay. So you have to know the details and locations of all the abscesses which are there. That is your Siteli's abscess, your Bizold abscess, your Lux abscess, your Lux abscess, whatever you call. Okay. This can even be asked in the OSCE also. Okay. What is identify what abscess is this? Okay. Second question is stages of brain abscess. I fumbled in this question and the examiner asked me how many cases of brain abscess have you seen till now, and my answer was 0. Sir, sorry, I have not seen any case till now of brain abscess. Complication of COM की complication में brain abscess बनता है. I didn't see any case till now also I have not seen. Okay, so he said, chalo, okay, move to the next question. And then the second examiner gave me the hint. Okay, what can be the stages? Just go through it. Okay, second question over here is lateral sinus thrombophlebitis. It's important. ठीक है, इसका आपको पैथोलॉजी पता होना चाहिए. Why pallor is seen over here? जैसे यहाँ पे आपने अभी नहीं, इसमें नहीं पूछा है. जनरल कंडीशन में अभी like we'll go ahead and we'll ask कि sir there is no pallor icterus cyanosis. As soon as you utter, you will get the question. Pallor कहाँ मिलेगा? तो lateral sinus thrombophlebitis. You should be ready with this answer. Okay. And यहाँ पे कौन सा साइन मिलता है lateral sinus thrombophlebitis में? Delta sign. Okay. And third question is what is picket fence fever? What is picket fence fever? Okay. Let's move ahead. Sir, there is no history of direct trauma to ear. There is no history of head injury, exposure to loud noise, consumption of any ototoxic drug. There is no history of any nose or throat complaints. Coming to past history, there is no known chronic illness. There is no history of any surgery in the either ear. Dr. Irfan, please mute yourself. Coming to personal history, he consumes a mixed diet. There is no history of smoking or alcohol intake. Bowel and bladder habits are normal sleep and normal appetite. There is no history of similar complaints in the family. No history of any allergy in the family. Allergy is important. Okay. Treatment history, you can answer, like if you have taken any treatment from outside, you can answer. Coming to summarize the case, a 22-year-old male patient without any comorbidity with complaints of otorrhea, left ear since 1 year duration, and hearing loss from both ear 1 year duration. The discharge is continuous, scanty, thick, non-foul smelling and non-blood stain. It is associated with hearing loss both ears since 1 year. This is only the summary till now. Only till now. आगे आते general physical examination. Please bear with me for the next 10-15 minutes. A patient is conscious, cooperative, well-oriented to time, place and person, averagely built and nourished, afebrile, pulse, BP and this. So afebrile is important. Why fever is seen? Where is fever seen? That is important. What is picket fence fever? It's important. When you read this lateral sinus thrombophlebitis, you will get all your answers. नहीं मिलता है, please come back, get back to me. Okay. Whenever you say this BP 126/76, please make sure that you have a stethoscope in the vicinity. It shouldn't happen that you say कि sir BP is this much and an examiner asks you how did you measure? So then you are looking at the sky. है ना? So God will not come down to save you at that time. Okay, so if you have not measured, so you can say कि sir I would like to take BP but I was not able to take it. After that, systemic examination within normal limit, and take a look at the examiner. Sir, shall I tell in detail about systemic examination? Sir, CVS S1 S2 normal, respiratory bilateral sounds heard, stomach, sorry, abdomen is soft, blah blah blah. So वो keep it in your subconscious mind. If he says tell me systemic examination, तो बोल देना, otherwise तो सब normally होना है. Coming to our bread and butter, that is the ear examination. Sir, ear examination, I would like to examine the right ear first and the left ear. Normally, many notions are there. How we were taught was to see the normal side first and then compare it with the deceased side. So whatever protocol is being followed in your institution, please follow the same. You have to start from your pre-auricular regions. Again, I am telling, exam pressure में सीधे tympanic membrane पे मत कूद जाना कि sir tympanic membrane I can see a PSRP over there. No, you have to start from pre-auricular region. Sir, pre-auricular region. I'm telling the right ear first. This, whatever you are telling, you have to tell the examiner कि sir मैं पहले ये बोल रहा हूँ. ठीक है, pre-auricular region no abnormality detected. As soon as you will say this thing, there are chances he'll say what abnormality you see in the pre-auricular region. You should be ready, sir. I can see a pre-auricular sinus, pre-auricular tag, pre-auricular fistula can be there. So pinna is normal. Again, standard question है. What is normal, abnormal, microtia, anotia? इसमें question जाएगा. Post-auricular region क्या दिख सकता है? तो you have to be ready with that. Two questions are there, that abscess can be there, ironed out appearance, that two questions can be there, and second mastoid you can answer, then third will be EAC. What can you see in EAC? One thing which I wanted to answer over here is that there is sagging of the posterior superior wall of EAC. Okay, in the cases of lux abscess, there is sagging of the posterior superior wall of EAC. Please remember this thing if you are answering. Okay, then comes to the endoscopy image of the left and right side. See, like in this patient, both the ear were diseased. Okay, so like example, suppose अगर ये वाला बात करते हैं हम लोग left side की. Okay, so generally in the when you describe the tympanic membrane, when we describe this thing, it was basically a virtual case presentation. Okay, so the thing you had to project on the Google Meet or Cisco, whatever platform we were having. So we had this option of using this laser pointer and telling. So this is how we were डंडा मार के याद कराया गया था कि you shouldn't jump directly on the positive finding. Sir, we can see this anterior malleolar fold. We can see the anterior malleolar fold, posterior malleolar fold, the head of malleus. This is in case whatever you are able to see, you have to tell this thing. One. Second, then you have to come, sir. We can see this cholesteatoma debris over this place. We can see a posterior superior retraction pocket. TOS grade 2 या grade 3. इतना बोल के रुक जाओ. ठीक है. अब जैसे ही you stop at this thing, TOS grade 2 or grade 3, and you look at examiner, give a pause for 2 seconds. He will definitely going to ask you, what if TOS grading? What is grade 2? So thug. You will get your full TOS. You will hit a 6 over there. So these are chances you have to create for yourself. The more you discuss with the examiner, more are the chances of getting better marks. Okay. After this ear examination, tuning fork test, you will mention, sir, Renev tuning fork 256, blah blah blah, 512, positive, negative, 1024, so and so, Weber, so and so, ABC, so and so. Okay, over here, tuning fork पे जो question हो सकते हैं, we have already discussed. Okay. What else can be there is okay, attic erosion हो गया, grade 3 हो गया, ठीक है. Okay, over here 2-3 questions are there. Tuning fork details you have done. What are the methods of doing Renee's test? There are 2 methods of doing Renee's test. Okay, tone decay and threshold method. Okay, so you have to name both of them. What is tone decay? What is vibration sense? We all know. Okay, what is speech frequency range? We all know. These questions were asked over here. Coming to the otoneurological examination, sir, fistula test is negative. Cranial nerve examination, no abnormality detected. Be sure कि वहाँ पे कुछ गड्ढा नहीं पड़ना चाहिए. If the patient is having any nerve ये तो please just make sure कि आपने देखा हो. It shouldn't be कि पूरा निकल जाए. Gait is normal, no spontaneous nystagmus, Romberg's is negative, no cerebellar signs. Coming to nose, no external nasal deformity. On anterior rhinoscopy, see, nose exam generally in ear case, nose examination is not important. But since this is a long case, so you have to complete it. Okay. So how how will you take on this nose examination? Sir, there is no external deformity. I did anterior rhinoscopy, columella was normal, and इससे पहले भी एक चीज बोलना है कि on lifting up the tip of the nose, I inspected the columella, which was normal, vestibule was normal, septum you can comment whether there is DNS or not. So since this DNA examination is not important for you, these all things are not important, okay? But keep it ready in case he asks you what else will you do in nose. So cold spatula test, Cottel's test, sign of tenderness and smell sensation. And throat examination is normal. Coming to the final diagnosis, this is basically chronic otitis media, bilateral squamous, left side active with moderate conductive hearing loss without any impending complication, and right side inactive with mild conductive hearing loss without any impending complication with adenoid hypertrophy. This patient had adenoid hypertrophy. But generally it's very rare कि जो exam case आएगा उसमें bilateral disease मिले, generally unilateral होगा. You have to answer this thing only for the affected ear. And after this, again the questions will again continue. How will you manage this case? How will you evaluate this case? So this is per se not important for you. Okay, over here. Okay, so over here I'll rest my case. Okay, please go through the questions. In case you find any other questions apart from these regular ones, please add up in the group. It will be beneficial for everybody. Still, I don't know what since we ENT guys have committed. अभी तक date नहीं दे रहे हैं DNB वाले. So more they are delaying, the more that 10th October wala thing is looking more feasible. Okay, the only problem which is to maintain your head calm and cool. Okay, so please behave like Mahendra Singh Dhoni, remain till the last over there on the pitch. It shouldn't happen that you stop studying कि अब मेरा पढ़ाई हो गया, मैं इतने में पास हो जाएगा. Believe me, अगर तुम 4-5 दिन का गैप ले लोगे, सब भूल जाओगे. Whatever मेहनत you have done till the last 2-3 months, if you will take a break of 5 days, 7 days at this period, so you will likely to forget most of the things. So please guys, again reiterating on the same things, OSCE are only for 100 marks. Case will be depending upon whether it's 100 or 150 marks. So it's equally important. And the remaining आपका word, viva, discussions and the tables which are there, they will be divided into 100 marks. अगर यहाँ पे they are not having enough tables and viva, so they might increase the case marks also. So it shouldn't happen that CM Commerce में you are lagging behind 50. My whole thing is on these 100 marks. Okay, CM Commerce में जितना भी आपका 60 plus आ रहा है, you will be making up for the OSCE sessions. You don't know, nobody knows what bloomers will be coming in those OSCE. 5 questions will be absolutely disaster. Okay, 15 will be aiming that हाँ 15 में से मेरे को सही होगा. Definitely you will get more than 50-60 marks. But people who are on the margins, है ना, जिनका last time 5 number 10 number से रह गया है, please again reconcile all your thoughts, see where those mistakes were done. Okay, and the people who are freshers giving it for the first time, in Hindi there is a kahavat, it's not halwa, it's not very easy. It might seem to you, but it is not easy. Believe me, it's not easy. I can tell you because I've crossed it, come on the other side. अभी मेरे लिए आसान है बोलना कि नहीं बहुत आसान होता है, कर लेना. But believe me, it takes a toll on our physical, mental health, like anything. Okay, so the more you score in your squamous case or in the long case, 10 marks, 15 marks, 20 marks, more you get, the same will act as a cushion over the OSCE things. Okay, the same will act as a cushion. There is a possibility that your one table viva might go wrong. Your one table viva, the examiner might be rude, he might be a little angry on you, he might not give you that much marks, 50% marks नहीं देगा. तो वहाँ पे जो आपको 10-5 नंबर का घाटा होगा, that you will make from CM's commerce oblique the long case which you are practicing. So over the next 2 weeks which are remaining, अभी 2 ही हफ्ते मान के चलो, ठीक है, 15 सितंबर तो चला गया, ठीक है, कि you have to give these 3-4 things: CM's commerce, larynx, oral cavity and thyroid. These 4 cases time. CM's commerce is the daddy of everything. You have to give maximum time over here. All the questions should be done. वहाँ पे गलती की कोई गुंजाइश नहीं है. Thyroid and all these things, please read as per your confidence, your this thing. Any problem, please let me know. And tomorrow again, we'll be meeting again. That same time. I'm sorry, I generally don't like to indulge myself or yourself on Saturdays and Sundays. But the problem is next week I'm going to some outside place, so it will be difficult to take classes. Net, I don't know whether in that place net will be there or not. So I will be sharing questions. That's not an issue. सब कुछ save PDF copies नहीं पड़ा हुआ है. But class I don't know whether I'll be able to take over the next week or not. So squamous का जिसका जो larynx का और general का जो case बचा हुआ था, tomorrow 45 minutes to 1 hour I'll request please take it out. Okay, we'll discuss the larynx in the similar way which like we discussed today. What all questions can be asked, what all you have to read, please go through it. And after that, in case you are having trouble in any topic, please let me know. We'll again plan a class per week. And I've planned two mock tests for you. One will be definitely be over there in the last week of September, probably around 25-26 uske aaspas. And depending upon the stability of the mind which everybody is having, agar last week October 1st week mein bhi ek test rakhna hai, so I'll be more than happy. Okay, so any positive or any negative comments, please let me know. Any inputs or anything which you want to be added, please let me know. The August session, guys, there's multiple things there are many things which have been still left to send to you. I'll be sending it slowly. In the next week, you will be getting all the data. Please go through it, and let's hope for the best. If anything for me, please let me know. We'll again meet tomorrow at the same time. Okay, chalo. Thank you so much. Bye. Good night.